to our live webcast, When to Order and How to Interpret Imaging in Pain Medicine. Thank you for joining us tonight. My name is Rene Przkora. I'm the Program Director of the Pain Medicine Fellowship at the University of Florida in Gainesville. I'll be serving as the moderator and one of the speakers for tonight's webinar. I'm also joined by our co-speakers, Dr. Wahezi, who's the Program Director of the Pain Medicine Fellowship at the Montefiore Medical Center in New York. He's also an Associate Professor of Physical Medicine and Rehabilitation, an Associate Professor of Anesthesiology, and an Associate Professor of Orthopedic Surgery. We're also joined tonight by Dr. Amir Jafari. He's one of my faculty colleagues here at the University of Florida, and Dr. Uche. He's one of our current fellows at the University of Florida in Gainesville. Again, thank you very much for joining us tonight. We will go through the presentations of Dr. Wahezi, Jafari, and Uche, and I will be the last one to present. During the presentations, please use the Q&A feature to ask any questions for the panel, and we will discuss all those questions at the end of the presentation. If you do not have enough time, again, we will send out emails with our answers. Again, notice your Q&A icon at the bottom of your screen, and feel free to submit your questions to the panelists or one single presenter, and we will respond to all those questions after all of our presentations. Again, thank you very much for joining us tonight, and I think I'll turn over the screen to Dr. Wahezi from New York. So yeah.
Thanks, Rene. Everybody, I want to thank really everyone who is with us this evening. I want to thank Rene for putting this together. Really, I believe that this is going to be an excellent exercise in thought, in education, and my hope is also to kind of make pain medicine a little bit more clear, because this is a topic that I think is underrepresented and undereducated in many places that we do our education. When I was a fellow many moons ago, it was part of my didactics to understand imaging, not only to know how to read it, not only to know how to order it, but also to know CT and MRI from its physical and physics basics. I'm going to share a little bit of that with you today. And the reason being, I think it just makes it more tangible when you understand things at that level. I will spend much of my time though on cases in hopes of allowing people to see and understand what things look like, what things should not look like, and how certain imaging, some images or some imaging rather may be preferred over others. Okay, so we'll get started here. All right. So really, this is my outline. It's as what I discussed: basics of MRI and CT, and then some case presentations. I urge everyone who's here with us tonight, as did Rene, to please ask questions at the end if you have. If there are questions that have gone unanswered, we will try our best as a community of educators to try to resolve any questions and confusions if there is any. All right. So an MRI, what is it? Well, it's magnetic resonance imaging. It is the way that I describe an MRI versus a CT is that a CT is an excellent way of looking at anatomy and certain anatomy. An MRI gives us information about anatomy, but can also give us information about physiology, specifically physiology that is fluid intense. All right. In many areas in our body, if there is fluid in places where there should not be fluid, for example, inside facets to some degree inside vertebral bodies, it means that there is something pathologic. It may not always tell us what the pathology is. It may also, but it may not give us an exact information about what the pathology is, but it may give us information as to rather that there is pathology there. And with more fine tuning of that information, you can actually understand the kind of pathology, meaning fractures versus tumors versus infection. All of that can be ironed out and can be understood if one understands the basic anatomy and then the physioanatomy that's changed based on the images that one is looking at. What an MRI does is it creates a magnetic field around the patient, specifically around the anatomical locale that the magnet is most focused on. And with different sequences, and by sequences, I mean a T1, a T2, stir images, fat suppression, which is a little bit different from stir. But with these images, the basics are, at least for T1, that protons are, the spin of protons are aligned, okay? So the magnet turns on, it aligns proton spin, and when the proton is that, or rather when the MRI is then stopped, protons that are loosely bound fall. Which protons are loosely bound? Well, protons that are in water molecules, right? If you remember what water looks like sterically, electrically, you've got an oxygen molecule, which is on the right side of the table of elements, right? You've got hydrogen ions, which are on the left side. They bind covalently. And basically what happens is that this oxygen essentially borrows or steals some of the electrons of these hydrogen ions. What that does is that allows these hydrogen ions to have, a polarity, positive polarity, whereas the polarity of the oxygen becomes negative. Now, when the MRI gets turned on, these hydrogen ions maintain a specific and consistent spin and elevation. When the MRI is turned off, instantaneously, forgive me, I'm losing my cursor here. These end up losing their spin dynamics, so they fall to a lower level faster than larger molecules. So when one considers an MRI, a T1 MRI, on a T1, fluid is low intensity. Why is it low intensity? It's low intensity because when that magnet is instantaneously turned off, then these hydrogen ions, again, their spin is then deregulated, and then you have a hypo-intense signal, okay? When it comes to T2 MRI, the principles are a bit more complex, and it actually has to do with the molecular size as well as the polarity of the molecules. And it doesn't just rely on spin rates, but it also it depends upon frequency of vibration. And when the magnet is turned off, the frequency changes, and then you see molecules of different weights represented with different colors, either dark or light, on an MRI. On a T1, the intensities are high, okay? And when I say high intensity, I mean it's going to be bright. Okay, so on MRI, we talk about high and low intensity. So fat is going to be high intensity on a T1 MRI, and fluid is going to be low intensity on a T1 MRI. On a T2 sequence, fat and fluid are going to be high intensity, and then low intensity are going to be things like muscle and bone, which will also, by the way, be low intensity on a stir, as well as a T1 as well. But the difference between the T1 and the T2 is essentially the fluid signals. And so when one is using those as a comparison, which, by the way, I think is important to state here, a T1 should not always be used absolutely to evaluate anatomy and pathology. It should usually be paired against a sequence of a STIR image and or a T1 to identify the pathology. And I think that that is an important thing to say here, because you'll probably see some of it as we move forward in at least this segment. I'm not going to begin to explain the physics behind STIR, because quite honestly, I don't really understand it. But simply put, for STIR sequences, these are inversion sequences that basically take away a fat signal while maintaining a fluid signal. So the fat signals will be low, so they'll be dark, and then the fluid signals will be maintained and they'll be high. Okay, the contrast between the high and low signals are such that it allows one to see pathology more easily than on a T2 sequence. All right, CT scan, a little bit easier to understand. Essentially what a CT is, it's a matrix. For those of you who remember being in physical chemistry, or who were unfortunate enough to take physical chemistry like me, we dealt with matrices. These are, a matrix is a set of variables, different equations with different variables that you have to, that one has to complete at the same time. All right. And one needs a computer really for that. We would have to do it by hand, and it took us forever to do. But in the Stone Ages, where we had our TI-82 calculators, that was something that was, modestly challenging. CT scan was around at that time, but there were much more complex algorithms to be able to complete or understand those different equations. So long story short, one takes an X-ray, and then at a different angle, another X-ray, at a different angle, another X-ray, at a different angle, another X-ray. And what a computer then does is it generates that information. It creates an intensity profile around different areas, in this case of anatomy, to understand or to demonstrate, to visualize, to create a picture of a scheme of grays or rather whites and blacks / grays, to create a picture, an anatomical slice. All right. And these are two-dimensional pictures as MRI, but it can be taken on a sagittal, a coronal, or an axial. All right. And I think that's something that I didn't mention about MRI, because I assumed everyone knew it, but I'll say it. It is important to understand that we're able to see on a CT scan and on an MRI are coronals, axials, and sagittal images. And if one if one can understand all three of those anatomical figures at the same time, that's when one can then create a three-dimensional picture in their head. Okay, and that's when things start to become real. And the more you look at these things, the more you evaluate these things, the better you'll become at creating that three-dimensional image. And understand, we live in a three-dimensional world, really a four-dimensional world. And that's how we have to look at things. And with MRI and with CT, the three dimensions, I think to most people are obvious. That fourth dimension is time. And on that fourth dimension of time, it's essentially the scrolling through of all of those things to be able to understand and create a three-dimensional picture. Four-dimensional, using four dimensions to create a three-dimensional picture in your mind. All right. CT scans are excellent at assessing bone. MRIs are not excellent at assessing bone. You can, but bone, especially periosteum, is low intensity. And when you consider that some of the anatomy around bone is also low intensity, like muscle, certain information can be lost. CT scans can be looked at to evaluate bone, like I mentioned. Again, better than MRIs. They can obviously be used to look at soft tissue, abdominal features, muscle, but the contrast between anatomy within the pelvis and the anatomy within a joint, and the anatomy between soft tissue structures in the gut are a little bit more difficult to see as compared with an MRI. The MRI gives great contrast. It's easier and a little bit faster to read these things. Radiologists rely on Hounsfield's units in order to identify sometimes pathology, okay, within these soft tissue structures. A Hounsfield unit of 0 is water. So water comes up as being black on a CT scan. And so when one considers, water and then gray scales, darker, which are more proteinaceous, and lighter, which are less proteinaceous, one can define structures within soft tissue structures within soft tissue structures. Okay, so understand that as well. It's very rare that radiologists will comment on Hounsfield units in a pain MRI. It's very rare that a pain physician will be able to know which Hounsfield unit or what numerical value of a Hounsfield unit a pancreas has, or CSF has, even though it is here, that's 15. You may not need it, but just understand that if you're having a conversation with a radiologist, that knowing some of these parameters may allow you to have a more intelligent conversation with that group, and really within yourself and within the people that hopefully you're being educated by and educating as well. Okay, I use CT scan primarily in my practice in the spine. For assessing for pseudoarthrosis. Okay, what is that? That's when one has hardware and hardware fails. Pseudoarthrosis is best assessed when there is a haloing around the metallic features, whether it is a hip, whether it is a pedicle screw within the spine. When one sees a lower Hounsfield unit that's more along like the CSF scale, but not CSF, but a lighter scale around the metal, then one can consider that there is movement of the metal within the bone. And that suggests that, if the metal is not stable within the bone, that may be a reason for why this patient is having pain and complaining of pain in your office. So post-surgery, if a person has fixation, consider pseudoarthrosis as being a possible pathology, especially if it's local and not radicular, although sometimes it does pop up that way. We're going to move into now anatomy and central canal stenosis. Okay. Simply put, what is central canal stenosis? It is tightness within this canal right here, the central canal, the canal that's bordered by the medial borders of the pedicle and the ventral borders of the lamina and the posterior border of the vertebral body. If it's the vertebral body axis that one is looking at. If it's at disc level, these things change a little bit. At disc level, we're not looking at pedicles. And instead of a vertebral body, we're looking at a disc. Okay, there may or may not be lamina at that level. So just consider those things. Okay, the things that cause central canal stenosis, especially in patients who have degenerative pathology, are shortened pedicles. That's what I'm supposed to show you. If these pedicles are short, basically what happens is that this space decreases. All right, we see short pedicles in tall males. Why? I'm not sure. But this is one thing that I've noticed often, and that actually has been documented as well. So tall males typically will have a smaller AP distance within their spinal canal, not universally, but commonly. So just be mindful of that. It can help because it can help guide a diagnosis. All right. Other things that can cause central canal stenosis. Well, this stuff back here that we call ligamentum flavum. Obviously, this is my cartoon, and ligamentum flavum is not red. But this is something that one has to consider. When my team and I were we're doing the mild studies and the encore and the motion studies that we've put together. We use 2.3 millimeters as the cutoff for when we would perform that procedure. I will tell you that the average ligamentum flavum thickness for patients who I do this procedure on is about 6. Okay, so 2.3 is still in my viewpoint still a little thin, but once you start getting into 4s and 5s and 6, it's very likely that you are cutting the space within this canal and likely causing a mechanical compromise of the cauda equina that lives in these lumbar vertebrae. Okay, so just be mindful of those things. Another thing that can cause central canal stenosis, well, when we get older, disc bulges. Why do discs bulge? I think I have a Kirkcaldy-Willis slide in here that's going to come up momentarily, and I'll discuss that briefly. But this here, you can see, will compromise the anatomy in this area as well. The compromise can either be a direct mechanical compromise of the nerves within this space, or a compromise of the venous and arterial system within that space that causes an engorgement in either a priori versus an oxidative pathology, or secondarily as a consequence of a secondary mechanical pathology causes encroachment of those vessels because they get blown up and then they cause a secondary compression of those vessels. Either way, we're talking about a mechanical or a physiological pathology as a consequence of this space becoming narrowed. There is debate in the literature as to what numerical value one should have in order to call one for one to call a space compromised. Many people will say if there's 50% decrease or less than 1 cm of space AP, that's considered essential canal compromise. The 50% being on the more serious scale. Okay. The acquired lumbar stenosis, we just discussed it. One thing I didn't discuss, we talked about the ligamentum flavum. One thing I didn't discuss was that within these central canals, another thing that can cause a central canal compromise is facet hypertrophy. Why facet hypertrophy? Well, because when you have the SAPs and IAPs, normally the SAPs become hypertrophied. When these guys become large, they actually encroach upon the central canal from lateral to medial. So what happens is you start to have encroachment within these lateral spaces of this central canal, and you start to make the central canal narrow. So we talked earlier about the AP aspect, right? Being narrowed because of the stuff that we described before. But this facet hypertrophy can cause narrowing here that can even more so cause a mechanical compromise. All right. And I'm hoping that makes sense. An MRI is choice to see this kind of pathology. It's a little bit difficult with a CT unless one is looking specifically for facet-related hypertrophy. It's challenging to see ligamentum flavum, and it's somewhat challenging to see disc-related, the differences between disc Hounsfield units and CSF Hounsfield units. So the contrast is a little bit more challenging to see on a CT scan. Can it be done? Yes. But the preference is MRI. Okay. Now there are some patients who can't have MRIs. We'll talk about that momentarily. I'm supposed to be showing you this disc bulge over there. Pathodynamics. This is kind of where we get into the Kirkcaldy-Willis phenomenon. And for those of you who don't know this, Kirkcaldy and Willis or Kirkcaldy-Willis, I'm not sure which it is, but it was described to be, the pathology or the pathogenesis of degenerative spine disease. And essentially what the description is it's a cascade. As one gets older, discs start to degenerate, end plates start to get close to one another. These posterior elements start to kiss one another. Facet hypertrophy happens. During these end plates collapsing, although that's a really dramatic term, but as these end plates starts to decrease, then what happens is that these discs remain with mass, right? It's the conservation of mass. It's the law of energy. And you have this conservation of mass. So this and this get close to one another. So whatever's in here bulges either anteriorly or it bulges posteriorly. And most of the time it's posteriorly because these anterior ligaments, the ALL or the anterior longitudinal ligaments, are tighter than this PLL. So they start to spread posteriorly. And that's why you have these disc bulges backwards that compromise the canal. Mother Nature is smart, very smart, but in some cases not brilliant. All right. So this is kind of what we're describing here. And then you'll get neuroforaminal stenosis as a consequence of this as well. Why neuroforamen? Because when these posterior elements, these facets start to collapse and these end plates start to collapse, it also encroaches, that also creates a decrease in space of these neuroforamen, right? Which the borders are the inferior aspect of this pedicle to the superior aspect of this SAP. Okay. You know, look, I'm not going to get very much into this. Everyone has different feelings about spinal stenosis. I actually consider disc herniations as a spinal stenosis as well. Now, there are differences between herniations, bulges, and so I won't get into that discussion because I think we may be having that a little bit later on, and we certainly can if we don't get deep into it. But just understand that I do consider a spinal stenosis a mechanical compromise, and a disc herniation is considered a compromise, usually of the central canal, but sometimes within the neuroforamen as well, because you can have these disc herniations out there. All right. CT scans. If a patient has an old spinal cord stimulator that is not compatible with an MRI, one may get a CT scan. What kind of CT scan? If you're looking specifically at central canal stenosis, a myelogram is preferred. Why a myelogram? Because when contrast is injected inside of the thecal sac, the contrast between, there's not really a pun intended there, but the contrast between the elements inside the thecal sac and the elements outside of the thecal sac become much more striking, so one can see those things. This is a patient of mine who could not have an MRI because she had a spinal cord stimulator, but also has a defibrillator as well. And so we needed to figure out, this is a patient who was doing well with a spinal cord stimulator for about 10 or so years. And then her leg pain and back pain were worsening. So we could not do an MRI. We sent this patient for a CT scan to define which areas this woman may need decompressive surgery. So in order to define that, we did the myelography. We saw that she has multiple levels of compression, but the most severe area of compression is right here. This represents L2, L3. There is certainly compression at L3, L4, and L4, L5. Now on the sagittal images, it appears like there's severe compression all throughout. But when we actually do our, in this case, physiological assessment to see what the actual CSF looks like, then we can see that the CSF did flow through L4, L5, a little bit less so through L3, 4, but almost none through L2, L3. So guess where this young lady is going to have her decompressive surgery. Okay, this is where a CT scan becomes helpful, and sometimes is even more powerful than an MRI. Okay. The one thing that I forgot to tell you about CT scan versus an MRI is, typically speaking, with MRI, the typical cuts in this country, in the United States, the typical cuts are disc cuts. So the cuts are done at the level of the discs. So some information may be lost at the level of the vertebral bodies. Whereas in a CT scan, usually the radiologist will get 2 to 3 millimeter cuts, and they're serial cuts. So you're going all throughout the vertebral body. So there's less information lost. Again, consider that when you are understanding what the information is between a CT scan and an MRI. Even though an MRI shows good contrast, there is some information lost. Okay. MRI, right? I think my hope is for most of you, this is obvious. This is a central sagittal cut in an MRI. Why is this a central sagittal cut, and how do I know this? Well, number one, an X-ray was done. on this patient. I know this patient does not have scoliosis, so this person is nice and straight. If this person is nice and straight, what that means is that these spinous processes are going to line up right on top of one another. Why is that important? Because when I'm taking a cut through this central canal, what this means is that if I can see spinous processes throughout, or even at one specific area, I know that I am positioned in the central space. Okay. Now, as far as cases are concerned, I want you to take a look at this axial cut. Okay. On this axial cut, remember what I told you before about what an MRI shows. And for those of you who are really paying attention, you know that this is an axial T2. So fat is going to be at a high intensity. CSF is going to be high. Okay. Muscles, disc is going to be low. But check this out. This muscle right here, this is multifidi. This is Erector Spinae. But these multifidi are wasted. Okay. This is a lady of about 86, 87 years old, and this person had selective wasting of her multifidi. I don't see this commonly, but I thought that I would present this to the group because this is almost like a low-grade spinal atrophy. Okay. There's general focal spinal atrophy of the multifidi. This person did not have medial branch radiofrequency ablation. This is a person who just came to me specifically complaining of low back pain that improved upon flexion. Why did it improve upon flexion? Because this person did not have the musculature to extend because these were gone. Normally what I see in patients is not the selective atrophy, but general and diffuse atrophy here as well. Consider that when you are discussing patients who have central canal stenosis. Let me rephrase this. For lumbar spinal stenosis without actually seeing central canal stenosis. Because if a person has general wasting of these muscles here, the reason why they may not be able to extend themselves is probably because these muscles are wasted. All right. We'll go neuroforaminal stenosis. We talked a little bit about this. Rene and I actually published a paper evaluating people, normal patients who are naturally straight, but then we curved them in the MRI, and we found a couple of, and we demonstrated things that were actually pretty important. What did we find? Well, if you have a true sagittal slice, I'm going to answer these questions. Yes, this is now not a true sagittal slice, but take a look at these foramen. Okay, nice and large, nice and large. They start to decrease in their patency when you get a little bit below. Why is that the case? Because when most cuts are taken on an MRI, okay, they're taken straight up and down. But the spine has a natural taper. If you do not taper these cuts to the pedicle line, which is a little bit more oblique, we call it a coronal oblique, what you'll find is this a false representation of this taper. You'll see small foramen and bigger foramen, which may not be naturally representative. Okay. If you bias these cuts, this coronal oblique on this angle here, what you'll find is that these foramen can actually be compared against one another. So basically what we're saying is if you don't have a coronal oblique, you cannot compare these foramen to one another. If you have a coronal oblique and you line up these pedicles with this line here, then they are comparable. And there's about a 20% difference in neuroforaminal size, even in a normal, healthy patient. If you consider someone who already has a neuroforaminal compromise and you drop their neuroforaminal caliber by 20%, guess what? You may have falsely diagnosed a neuroforaminal stenosis. Okay. Long story short, this is what our article is about. If you want to read it, we hope that you do. All right. But essentially, the talk goes into what would happen if we were to accentuate this curvature. And for those of you who are advanced thinkers, which I know most of you are, the numbers get worse. Okay. And we'll leave it at that. Even on the axial. So one of the things that we talked about on axial is you have to understand your anatomy. If the axial cuts, again, in this country, if the axial cuts are being performed at a disc level, these nerves have already exited. So if you see neuroforaminal stenosis at a disc level, it may not be clinical. So, and or it may not be pathological. That may not explain the patient's clinical pathology. If, on the other hand, the cut is performed at the level of the nerve, which is at the highest level of the disc or at the lowest level of this end plate, and you get a cross section of the nerve, that's when an axial section is most reliable. If a percenneur is tilted, or if the angle is tilted even by 10 to 20%, you get a false degree of stenosis. Okay, again, just because we thought that we'd mention it. In this particular case, this patient is curved, the line is straight. And so what happens is you get a false degree of stenosis one side versus another. How do we know this is false? Because when we straighten this patient out and we got the cuts at the level of these discs or a little bit higher, this normalized, okay? And this actually demonstrated more than 50% decrease. So again, consider that. And again, these are really important when you think about the things that we're going to be responsible for in now and in several years, and that is understanding when to perform miles, when to perform endoscopic surgeries, when to perform spinal cord stimulators, and how to have a discussion with our surgical colleagues. Okay, so this is important for all of us. We talked about this. This is a patient who has epidural lipomatosis. How do we know this person has epidural lipomatosis? This is a T1 sagittal, which demonstrates a contrast between the CSF and the fat. On a T2 image, you would not be able to see this contrast. So it's valuable information to see this here. This is a T2 axial. T2 axial demonstrating that these nerves here are clumped with the fat that surrounds it. We confirm that this is fat because we use the T1 here and a T2 there. Okay, so this can be helpful. If we looked at a T2 and a T2, we may not have seen that information, or we may not have identified this. Okay, this is a patient who had an epidural abscess. It's a patient who came into our office complaining of right-sided leg pain, had a lemanotomy, or rather lemanotomy on the right side. And this patient began to have worsening pain on the right side. A CT scan is not optimal for this. And a CT scan may not be preferred for this. If you think that this is pathology, I advise you not to get a CT scan with a myelogram. CT scan by itself would not be able to show this degree of contrast. And a CT myelogram, one would just be taking the goo that's living within the epidural space and delivering it right inside of the fecal sac. Obviously, that's going to create a meningitis, right? And potentially death. So choose your imaging thoughtfully, okay? This is a patient who came into our office who was complaining of low back pain. MRI was completely normal. Patient had prostate CA, had radiation and also chemotherapy, but the chemotherapy that they had was leuprolide. One of the things that we knew about leuprolide is that it actually causes a myositis. So we got an MRI of the pelvis, and what did we see? We saw iliopsoas inflammation. There's only one thing that could cause this degree of intensity on a fat suppression image. How do we know it's fat suppression? This is the fat layer here. It's low intensity. This is muscle. It's on the grayer scale a little bit more. Marrow has fat in it, so it's low signal. And then what you see is a much higher signal right along this muscle here. Okay, so we had to treat this patient, or rheumatology then had to treat this patient for the myositis, and the patient recovered. CT scan would not have been helpful because CT scan would not have been able to achieve this degree of contrast. If an MRI was performed without a stir and only with a T2 slice, this may not have been seen. Why? Because on a T2 slice, fat would still be a high signal. So the degree of contrast between this bone, which has fat in it, and between this line of inflammation would not have been clearly seen. An ultrasound, which is great to see fluid, okay, may have been An appropriate test may, if this was a superficial muscle, but because this is deep, an ultrasound would not have been able to penetrate the 7 or 8 cms to be able to see this, okay? I'm almost done. CT scan, you know, I mentioned before, if I'm evaluating for pathology that evaluates os, this is what this is my primary test. This is a patient who was on our table for a spinal cord stimulator. I was just about to do the spinal cord stimulator. He had an MRI. He was post-operative, had a surgery at T1 several years ago, had a fusion as well, had several MRIs of a lumbar and thoracic spine, you know, didn't demonstrate anything that was surgical, meaning there was no surgeon who thought that this person could be improved surgically. He was complaining of back pain primarily. We set him up for a spinal cord stimulator, and on the table, what we determined was this guy has no interlaminar space, none. I've never seen that before. We then sent the patient for a CT, and I thought that the patient had ankylosing spondylitis just because I did not see any interlaminar spaces. What we then did was we sent him for a thoracic and a lumbar CT scan. Okay. And what you see is a clear line of demarcation, a clear line here. And this is all fused spinous process. Okay. This is an MRI of a sagittal slice. You cannot see it. It's extremely difficult to see here, but on the CT scan, very clear. Again, choose your imaging thoughtfully. Okay. And you may avoid doing what I did and putting a patient on the table who has ankylosing spondylitis for a spinal cord stimulator. And that's what I have for you guys and gals, okay?
Wahezi, thank you very much for your presentation. Also the initial slides, you know, explaining a little bit the technology, the background. So, you know, when we consult with our radiology colleagues, you know, we all sort of show a common understanding of the technologies we're going to use, especially as we're advancing on more advanced procedures, interventions, and diagnostics. It's my pleasure to introduce Dr. Jafari from the University of Florida. He will be giving his presentation now about vertebral pathology. Dr. Jafari.
Hello, thank you.
Looking forward to your presentation. Thank you.
I appreciate it. I'm going to go ahead and share my slides here. All right. So I'm going to real quick go over the basics of MRI. Again, this is much more quick than what we just heard. Again, on MRI, fat is bright on T1 and dark on T2. CSF is bright on T2 and dark on T1. Spinal cord is dark on both T1 and T2. And as we heard, STEER is basically, I use STEER for evaluating, for example, patients with a vertebral body fracture to see, to look for edema, which basically shows that how acute, subacute, or even chronic this fracture is. Now, when you obtain an MRI with IV contrast, again, I usually look at T1 in the image with and without contrast to compare it, and have used it to evaluate for presence of infection in that area. Now, one of the topics that's been a hot topic in the pain world right now, especially with the new procedures coming out, is Modic changes. Now, what is Modic changes? Look at the spine. Looking at the spine anatomy, the disc itself is a very avascular structure. Doesn't have a lot of blood vessels. So, and it's surrounded by the end plates, which are basically pure bone with a lot of blood vessels in it. And when on an MRI, when there is signal changes in the vertebral body end plate or the adjacent bone marrow, that's when we call it Modic changes. Now you have to understand that the new procedures coming out, they rely on the wording of the MRI report. So not always you will see the word Modic changes. Sometimes we'll see bone marrow edema, fatty degeneration, or osteosclerosis. That's why it's important to be able to look at your own images and also evaluate the patient for these procedures and not just rely on the report. Now, how does Modic changes occur? Usually there is either disc herniation, degeneration of the end plate. Other things that can cause this is patients with history of smoking, old age, spinal deformity, poor genetics. Anything that causes defect in the end plate basically will lead to leaking of these disc material into the end plate area. And this disc material will activate this inflammatory cascade and start the process of inflammation in the end plate, which is a highly innervated area, and it can be quite painful. And this process can lead to the end plate edema. Now, this area is innervated by the vasovertebral nerve, which is a target of one of the most recent new procedures. It's not so new, but now it's become very popular. It's the intercept procedure, where we basically use a ablation device to ablate these nerves. Now, remember that this end plate changes can progress or regress over time. So it's appropriate to start with conservative treatment and see these patients improve with time. Now, there are 3 types of Modic changes, and type 1, 2, and 3. And all these 3 are different stages of the same pathology. It just progresses as you go from 1 to 2 to 3. Type 1 is the initial stage where you get fibrovascular tissue thickening, which ends up lighting up just on T2. Type 2 is when this fibrovascular tissue is replaced by fatty marrow now. This one lights up on both T1 and T2. And type 3 is when there's sclerosing, hardening of the bone, and it's dark on both T1 and T2. And it's type 3 that really our treatments will not work on. Here's an example of a type 1 Modic change. On the left, you will see that it's T1, and on the right, it's T2. It's hypodense on T1, it's dark, and then on the right side, it's much more bright. This is a Modic type 2. Again, it's bright on both T1 and T2. The way I remember it is type 2 is bright on both. Type 1 is only bright on one of them, which is T2. And type 3, it's dark on both. And this is an example of type 3, which you see there's a hypodense, and both T1 on the left and T2 on the right. Now, you have to understand that patients with vertebral body fracture are also going to present with edema, but not just in the end plate. This edema is going to be in most of the area of the fracture. So pay attention to that and evaluate the patients for that. Just because there's end plate edema, it doesn't mean it's just Modic changes. Now, some of the other pathologies that rare, but you should be aware of, and sometimes you can catch it and refer the patient to oncology. Multiple myeloma. It is a malignant proliferation of monoclonal plasma cells within the bone marrow. This can cause quite a bit of vertebral body bone pain. Almost 75% of patients present with a lot of pain. And this can lead to anemia, infection, the blood cells are not being produced appropriately. So either they have low hemoglobin or low red blood cells or low white blood cells. They also end up with hypercalcemia, a lot of breakdown of bone, which can lead to increased level of calcium in blood. Now, treatment for this could be supportive analgesia, bisphosphonate, which basically inhibits the osteoclast activity and reduce the breakdown of bone, erythropoietin, which helps improve anemia, local radiation, chemotherapy, transplant. Again, these are all, out of our specialty, and we refer them out. Here's an example of what you would see on a patient with multiple myeloma. Again, if you see abnormalities in multiple levels, you should be concerned. It's not something that's a usual finding. Here on this area, you see this and you think, oh, this patient has Modic changes, end plate edema, but then you look at the whole picture and you see it's everywhere. So diffuse idiopathic skeletal hyperosteosis. Again, this is when the multiple vertebral bodies fuse. Just like a patient with ankylosing spondylitis, when you see that the spinous processes are fused, this is the exact opposite side where the anterior part of the vertebral body starts fusing. And when this happens in the neck, the patients can actually complain of difficulty swallowing because it's so close to the esophagus. Now, to make an official diagnosis, you'll need 4 adjacent levels to be fused. Treatment for this, again, it's suppurative, conservative measurements, but if it's pretty bad and they're having difficulty swallowing, affecting their life, then probably need resection and surgery. This is the, looking at this image right here, this is the anterior portion of the vertebral body, and you could see the fusion very close in this area to the, it's actually going very anterior. Ossification of posterior longitudinal ligament. So this vertebral bodies are surrounded by the anterior and the posterior longitudinal ligament. When we do transforaminal epidural steroid injections, a lot of times when we actually inject the contrast, we see the posterior longitudinal ligament light up, and it's actually pretty close to the disc as well. And when this, and also very close to the dura. So when you have an ossification of this ligament, which is supposed to be a thin ligament, then it can definitely cause some problems such as stenosis in the spine. Now, most people are asymptomatic, you know, you just observe them, but when the stenosis gets pretty bad, then they may need a decompressive surgery. And this is the example of how thick it can get, and look at that, how narrow that spinal canal is right there. This is in the neck area, and in this area it should be the normal level, and you can see as you go up it will start extending posteriorly into the spinal cord. Looks painful. Another thing that's actually an incidental finding most of the time, it's hemangioma. Again, this is a benign venous malformation within the vertebral body. I've seen this quite a few times, actually, not too severe, but I have seen it. Again, on CT, this is a very well circumscribed hypodense lesion. It kind of looks like polka dots on the axial image on a CT. And on an MRI, this will be very hyperintense on both T1 and T2. Now, these patients, you see them, you just follow up with them. You really don't treat this. You do, annual radiologic evaluation. You do repeat imaging, make sure it's not getting worse. But if it's a pretty aggressive hemangioma, they may need embolization, surgical resection, or even radiation therapy. This is an image. It is a T2 on the left and T1 on the right, and you can see how it lights up on both T1 and T2. Dr. Przkora, that's my time. I'm going to hand it back to you.
Dr. Jafari, Amir, thank you very much for your presentation. And I'll be fair, I think we cannot hear it often enough, what is T1, T2, and the stir sequences, because, most of our diagnostic tools are based on MRI. So I appreciate all those repeats, because I think that's gonna improve our knowledge and gets it in our brain. I think it's my pleasure to introduce Dr. Uche, one of our pain medicine fellows at UF, and he will talk about the sacroiliac joint. That's correct?
That is correct. Good evening, everybody.
Welcome.
All right, thank you. Let me go ahead and share my screen. Okay. All right, so our objectives are to identify when to order imaging for sacroiliitis, identify how to interpret the imaging results along with limitations of our chosen modality, as well as to identify the best imaging modality for diagnosing acute sacroiliitis. I have no conflicts of interest. So we know sacroiliac joint pain is a common cause of low back pain, about 15 to 30%. There is no pathognomonic physical exam finding or even like an imaging feature that reliably establishes SI joint pain as a source of chronic pain, but a combination of both provocative maneuvers and imaging can help guide our diagnosis. We also know that in the acute phase of sacroiliitis, conventional radiographs are often normal, but hence other modalities such as MRI can help detect acute inflammation. We also know that sacroiliac joints are involved in most cases of spinal arthropathy, with sacroiliitis being one of the first common manifestations. Hence why ASAS, New Assessment of Spinal Arthritis International Society, they had developed a criteria which helped, which actually included MRI imaging as a means to facilitate early diagnosing and assessment and treatment response due to the fact that MRI was able to detect active inflammation. This table here, table 1, depicts imaging techniques used to diagnose sacroiliitis. Of course, pelvic x-rays, CT scans, and also magnetic resonance imaging, MRI. The question is, when should we pursue imaging of the SI joints? It could be to help make a diagnosis of ankylosing spondylosis. It could be to help clarify our diagnosis in patients with inflammatory back pain, maybe to even determine the amount of actual inflammation or chronic changes present. It could be to exclude septic sacroiliitis, and maybe even to evaluate patients with widespread pain. All right, this here is the X-ray grading of sacroiliac joint. Of course, grade 0 would be normal. Grade 4 is completely fused, ankylosed SI joint. Grade 1 would be where you have suspicious changes. But I want to draw your attention to grade 2 and grade 3. Grade 2 and 3, they both have erosions and sclerosis into both the iliac and the sacrum portion of the joint space. But in grade 3, you have either a decreased or widening of the joint space and partial ankylosis, as indicated here above. And in grade 4, you have complete ankylosis, but in grade 2, you don't have any changes to the SI joint space. So you have a normal joint space. Here on the left, this is a normal SI joint. You can appreciate a nice SI joint without any erosions or sclerosis or bone marrow edema or any kind of inflammatory changes that we might indicate on an MRI. Here, on the right image here, you have grade 1, minimal changes on this left SI joint, but on the right, you can start to see some form of erosions and sclerosis, not really a lot of widening of that joint space. So hence, another modality we can often choose is CT scan. Of course, we know that you're exposing your patient to radiation, so choose your scan or your imaging wisely. It's more sensitive than the X-ray for structural changes. It's inferior to MRI as far as the detection of any kind of earlier acute inflammation. The positive is that you're able to cut the SI joint into slices to help you, of course, identify more inflammatory changes, to assess for erosion, sclerosis, joint space narrowing, as well as ankylosis, and even to assess the ligamentous portion of the joint. You can also, of course, identify inflammatory changes, which can be quantified and monitored. You can detect small subchondral lesions and erosions and bone marrow edema, as well as detect enthesitis and capsulitis and differentiate synovitis from joint effusions with assistance of contrast as well. Here is a CT guided image of the SI joint. And over here, you're able to appreciate a lot of the sclerosis and also erosion of this joint space and widening. Here is a little bit much more narrow. And on the right here, you have a progression of the disease, of course, erosion completely into the sacrum and also into the iliac aspect of the joint space. All right. So ACEs had developed a criteria in 2009, which is further modified in 2016. And this allowed the utilization of MRI findings to facilitate early diagnosis and, of course, begin treatment response earlier in detecting active disease or active sacroiliitis or inflammation in the joint space. To be able to apply this criteria, the ACEs criteria applies to patients who at least have 3 months of back pain and who were less than 45 years old at the time of diagnosis of the pain. If I was to draw your attention to table 1 of the ACEs criteria here, you can see that the criteria calls for acute inflammation at imaging or MRI imaging with bone marrow edema and osteitis, or definitive radiographic changes according to the modified New York criteria, which is over here on the right. With this modified New York criteria, it calls for sacroiliitis grade 2 bilateral or grade 3 to 4 unilateral. So that's one criteria, or you can either have limitations on chest expansion, of course, relative to age and sex, or limitations of motion of the lumbar spine with both sagittal and frontal planes, or low back pain and stiffness for more than 3 months, which improves with exercise not relieved by rest. So that's one criteria. Plus, you also have to have one feature of spondyloarthropathy listed over here. So that fulfills one criteria. Another way you can fulfill the criteria is you have a presence of HLA-B27 and at least 2 other clinical features of spondyloarthropathy, which of course the back pain, arthritis, enthesitis, uveitis is indicated here. So in applying this ACEs criteria, you're able to utilize MRI findings as a means to help diagnose or detect active inflammation. Hence, you can begin treatment faster and earlier. All right, so we know, of course, sorry, I skipped a slide. MRI can also be utilized, of course, to detect active inflammation. It's more specific and sensitive compared to CT. You can utilize your T1 weighted sequence to help detect structural changes. If you're looking for more acute inflammatory changes, consider your STIR sequence or your fat saturated T2 weighted sequence, or even your T1 weighted sequence after administration of contrast material. So this here is a coronal oblique T1 weighted image on the left without, and on the right here with fat suppression of a 33-year-old male with ankylosing spondylosis. And what you're able here to appreciate is the periarticular fatty deposits over here with the arrowhead indicating that, as well as the subchondral iliac sclerosis of the right iliac joint space. But what you're able to appreciate is you can note how the joint space here is better depicted after fat suppression. So it's a comparison. You're comparing the fat suppressed to the non-fat suppressed. Here's a coronal oblique fat suppressed T2 weighted image of the sacroiliac joint space, which depicts bone marrow edema. So this is a typical picture of the ACEs criteria of how you can compare or attain MRI imaging to detect active inflammatory changes in the SI joint. You can also utilize the STIR, which we talked about, the fat suppressed T2 weighted, and the contrast enhanced fat suppressed T1 weighted images, which demonstrates bone marrow edema as the increased signal intensity as indicated here around bilateral SI joints. All right, this is a coronal oblique fat suppressed T1 weighted image before contrast on the left and after contrast on the right. And what you're able to depict is, this is highlighting the enhancement of the synovial portion of both joints, there and there. Of course, before contrast, which lights up even better after contrast, as well as spondylodiscitis, basically large erosion of superior 1 end plates, as indicated by the arrow around this area here. And this is depicting inflammatory changes. Here's a coronal fat suppressed T2 weighted image on the left, as well as a contrast enhanced fat suppressed T1 weighted image on the right. And they both demonstrate bone marrow edema and synovitis. that's depicted by the arrows in these areas here. And you can kind of appreciate how the T1 weighted image with contrast kind of similar to the T2 weighted image. Of course, fat suppressed. And this here is a coronal fat suppressed T1 on the left and the axial fat suppressed T1 weighted image with contrast on the right. And what you're able to appreciate here is enhancement of the ligamentous aspect of both joints, as well as into the foramen. You can kind of identify that, as well as swelling here, or not swelling, excuse me, enhancement of the right facet joint here, which indicates inflammatory process. This image here is a T1 weighted image obtained without contrast on the left, excuse me, without fat suppression on the left and with fat suppression here. This is with fat suppression, without fat suppression on the left and with fat suppression on the right. And what you're able to appreciate is the fatty deposits in this area, which was hyperintense, and here was hypointense. But you're also able to appreciate or distinguish the fat suppression within the joint space, which you're not able to see that well here. And this is a coronal oblique T1 weighted image of another gentleman with, or 61-year-old male with ankylosing spondylitis, showing complete fusion of both SI joints. You can't appreciate any sacral or iliac component of the joint is completely fused. So of course, this will be like a grade 4, and of course your X-ray or your pelvic radiograph will identify the same finding. So again, according to the ACEs criteria for axial spondyloarthropathy, arthropathy, the presence of subchondral and periarticular bone marrow edema is mandatory for the definition of sacroiliitis with MRI imaging. If there's only one lesion, it should be present in at least 2 sections. If there's more than one lesion on a single section, then that would suffice. Now, the presence of synovitis, capsulitis, and enthesitis is consistent with, but it's not sufficient to make the diagnosis of active sacroiliitis. Also, structural changes or lesions such as fatty deposits, sclerosis, erosions, and bone ankylosis are likely to reflect previous inflammation, but they did not suffice for the definition of positive MRI imaging. And another reason why, of course, we get imaging would be, of course, to formulate a differential diagnosis or rule in or rule out other pathologies which we think may be there or present, such as osteoarthritis, septic sacroiliitis, insufficiency, sacral fractures, osteitis condensi ilii, and bone tumors. And these often mimic the inflammatory lesions seen in spondyloarthropathies, but sacroiliac inflammation in spondyloarthropathies they're usually limited to the bone in the sacroiliac joint space and don't cross anatomical borders. So if you draw your attention to this image here on the left, this is a septic sacroiliitis in a 14-year-old boy, evidenced by a fat suppressed T1 weighted image, which shows basically articular effusions and bone marrow edema highlighted there as well. And what you're able to appreciate is this intramuscular abscess and inflammatory soft tissue changes indicated over here. And that's basically, this is my reference, and that's it.
Okay, thank you very much for your presentation, and we're using, the sacroiliac joint as one example how we can look with our diagnostic images tool at peripheral joints. For example, you can translate it, for example, to the knee joint and to the shoulders. And I think I don't see any questions in the Q&A box yet. I know about the time, but I think I will move forward and share my screen and start my presentation about a lumbar epidural or epidural hematoma and lumbar disc disease. All right, here we go. going to move this around. Good. I hope everyone can see my screen. Again, our session is when to order and how to interpret imaging in pain medicine. Those are my disclosures. They're also available online. I have no financial relationship to the topics I'll present tonight. I'll talk about spinal epidural hematoma and lumbar disc herniations. Spinal epidural hematoma. Back pain, reflex, immediate evaluation. Again, we're talking about when to order imaging. If you have new neurological deficits, including extremities, progressive neurological deficits, saddle anesthesia, anal sphincter weakness, urinary retention. So if you think about it, think about spinal epidural hematoma. What is it per definition? A spinal epidural hematoma is a collection of blood in a potential space between the dura and the periosteum. It's usually venous in origin, and the etiology is usually, when you look at most of the cases, is spontaneous, especially in the context of a bleeding disorder or anticoagulation, of course with trauma, and then iatrogenic, for example, from a lumbar procedure, puncture, epidural anesthesia, the interventions we perform to help our patients suffering from pain. Now, again, if you think about there might be an epidural hematoma, it is an emergency. When remotely considering it, order imaging and communicate your concern, for example, to the radiologist and to your spine surgeons. As the hematoma can expand over several segments, usually the recommendation is, if possible, to image the entire spine. So you see the extent of the hematoma and also to help with the surgical planning or expedite the surgical planning. When you look at a spinal epidural hematoma, the diagnostic tools you have is CT. It's usually initially non-contrast. You see a hyperdense extradural mass. And if you look at the MRI, that's the recommended diagnostic tool if available and the patient can undergo an MRI. You will notice that the signal characteristics will vary depending on the age of the blood. So when actually the hematoma was formed, we're going to see here the different stages. There's hyperacute within 24 hours, acute, subacute early, and that those signals will change if the hematoma is more than 2 weeks old. And you see here explained how they look like on T1 and the T2 sequences. Again, spinal anatomy here. I know it's late in the evening. You see here in yellow the intermediary space, subarachnoid space, the subdural space, and the epidural space, where you're going to look for your blood product or any other compressing material. Again, you see the sagittal slides and you see the axial slides. Again, it's T1 and T2. And we're moving to the next slide. Here you see an example for an acute is a T1 and a T2 weighted slides, sagittal here, and then the axial corresponding slices or sections here. You see here the epidural hematoma, and you see here on the T2 the epidural hematoma, and then if you look at the axial slide, corresponding lesions, you see the blood products here and here. Let's move. I'm sorry for this. Let's move to the next slide. Again, you may also notice there is an option. It can happen. You can have a spinal subdural hematoma. The subdural hematoma occurs in the potential space between the dura and the arachnoid mater. And it looks like, for example, here as it is in the subarachnoid space, not in the epidural space, you usually see that the epidural fat as displayed here is still well maintained, and this is one radiological sign that you are looking at a subdural hematoma. Just as an excerpt on the presentations tonight. Again, if you have a CT or you need to, patient cannot undergo an MRI, of course you can do a CT scan. And here you also see the hyperdense extradural mass, and this time it's the blood products. You see the Hounsfield units 50 to 70. You see the hematoma expanding here. You see the hematoma expanding here. And if you look at the sagittal view, You see how the hematoma is expanding here, and again, over several levels. So even if you have done, let's say, a procedure, and you know this was, for example, done at L4-5, and you think that your procedure is maybe the cause or associated with the epidural hematoma, try to expand the imaging, because the epidural hematoma can expand over several levels. And again, we're talking about time is function, is loss of neurological function. So to expedite also the planning for our surgical colleagues, consider to expand your imaging beyond the area of concern. Let's talk about, at the end of tonight's presentations, about lumbar disc herniation. Again, when you're going to order imaging, if the symptoms, mainly let's say pain, are not improving, if you want to help with the diagnostic and also the treatment planning, it's legitimate to order imaging. Certainly, if you have neurological deficits on the initial presentation, or if they develop during the treatment course. Now, because remember, if there's compression of neurological structures, time and not providing a decompression will have a detrimental effect on the patient, and the function will not recover. If uncertainty in the diagnosis, for example, also Dr. Jafari and Dr. Uche talked about other things we do see, maybe not often, but we do see and actually do treat in pain medicine. Preferred technique, again, if available and the patient can undergo to describe lumbar disc pathology, is the MRI. You heard a lot about bulging versus herniated discs. There are several definitions out there. I'll give you one here. Bulging disc is a generalized displacement of the disc over 25% of the circumference of the disc, symmetric or asymmetric. Now, in comparison, a herniated disc is the localized or focal displacement of this material of less than 25% of the disc circumference in the axial plane. What does it look like here? Again, this is out of a common textbook. I have the references provided on the slide. You see here, if you go up here, this is the normal disc comparison. This is diffuse disc bulge. It's going the entire circumference, and then you're going to see the protrusion. You're moving along, you have a focal protrusion. Again, this is less than 25% of a circumference. And if you talk about protrusion, extrusion, sequestration, again, those are the subterms for a disc herniation. If you look about the definition here in the middle of the slide about a disc extrusion, that usually means by definition that, again, it's less of 25% of the entire disc circumference. Yes, that's correct. And the largest diameter of the extrusion is larger than the diameter at the base of the extrusion. Again, if you're moving along, for example, the definition of a sequestration, sequestration means that the disc material does not have any contact to the remaining disc. Moving along, we're having several zones and levels of disc displacements. If you look at the images, if you talk to our colleagues, and also when we talk to our surgical colleagues, you're going to see there is the central canal zone, there's the subarticular zone, the foraminal zone, and the extraforaminal zone where you can have where you can find disc material. Now, if you also can look at several levels where it can affect, for example, the corresponding nerve roots, you're going to have the central canal zone, again, the subarticular zone, the foraminal zone here, extraforaminal zone, and then again, you can have the disc material can be found at the disc level. The infrapedicle level, sorry, let me see my pointer here, at the pedicle level, and also the suprapedicle level. So depending where you find your disc material, it may also correspond to the nerve root involved, or you may thinking about a different nerve root or a different level of disc herniation. But then when you look at your imaging, you see where actually the disc material is, it makes sense when you correlate this with the corresponding, for example, nerve root, which is bypassing the disc material. Let's move along. Again, there's a similar slide. It's a slightly different graphics. You see again the different zones and levels of disc displacement. Again, remember the central canal zone, the subarticular zone, the foraminal zone, and then the extraforaminal zone where you can find disc material. What can it look like on an MRI? Again, this is out of one of our very common textbooks. And you also have the image descriptions at the bottom of my slide, so you can review it in case I'm going too fast tonight based on the timing. Again, if you're going to see here, you have T2 image, the sagittal view, and then you have axial T2 images at the corresponding levels 3, 4, 4, 5, and 5, 1. Again, this is one patient. And you see at 3, 4, you see there's a normal pathology. And again, remember the beauties of images, or even on your physical exam, sometimes you can compare. There are corresponding joints, there is right and left joints, there are corresponding disc levels, spinal levels, which you can compare where you think this is something not looking right. There may be a pathological finding versus this is normal. Again, 3, 4 is normal. You see a very well-maintained disc. Then if you're moving to the level 4, 5, you see this is a central protrusion, and 4, 5 going here into the central canal. You see it here in a sagittal view. And then if you go to the most distal level, this is L5, S1, we actually do see a central disc exclusion here. And if you would look also in a sagittal view and more slides, you would see this is not in contact anymore with the, I call it the main disc. Let's move along to some more images also out of this textbook I mentioned. Again, you see here axial T2 and T1 images, and this is at the level from S1. And we do here see again the disc material, and then we see the disc material here with the different MRI sequences. And then we also see something here where we actually see how the different types of sequences can help in the diagnosis. You see here there's a big fluid-filled ring around the disc material. This actually shows us all. This is the inflammation. Again, this also further adds to pain, and with inflammation and tissue swelling, which also can compromise the neurological structures and can either cause a deficit or certainly pain. And as Dr. Jafari mentioned, you also see on the sagittal view here on the picture H, the Modic 1 changes. Now, when we move to the next slide, and this will be one of the last slides, again, you see here on the sagittal view, this is one patient with left S1 radicular pain. You see here, let me find my cursor, again, the disc material expanding beyond the normal line of the disc. You see here on the axial image, you see that it is protruding, extruding into the central canal. And then when you look at this, is the pictures, the two pictures to the left, and then the two pictures to the right are the same patients. There's just, I think, 4 years later. And now you also see, interestingly, the same patients, hopefully the natural progression of this disease, that this material, what you see on the right, has been absorbed. And the patient was sort of maintained in the initial year with epidural steroid injections. Again, the disc material was taken up by the body. The symptoms resolved, so no advanced surgical or procedure intervention was necessary. However, unfortunately, 4 years later, the patient presented with a disc pathology at the level above at 4, 5. So just for you to look also to understand, hopefully, the natural progression, or sometimes, as we see here, improvement of disc pathologies. Again, this is the end of my presentation, and I will stop sharing my screen. And again, it was a pleasure having you all on tonight. We have a few minutes left. I know it was a long evening after hopefully a busy clinical day. I do not see any open questions in the Q&A features. Again, for the one who are still on and listening, feel free to ask any questions. If you don't have time or don't have access, feel free to email it to Azra Payne, to the host of this meeting. So we'll be happy to review and answer all questions. I was asked if the presentations will be posted online, made available to the membership. Short answer is yes, once we get the permission of the authors / presenters. Again, this is the chance, and there was a lot of information. I also realized, we were not able to cover all the broad variety of imaging and areas and diseases and conditions we can treat and touch as pain physicians. But I think this was a good and initial step to start thinking about the diagnostic tools we're using in pain medicine. And I still don't see any questions. So I would say thank you very much for joining us tonight. Thank you very much, Dr. Wahezi, Jafari, and Dr. Uche. And thank you very much for Azra Payne for hosting this webinar together with the APPD. This is the Association of Pain Program Directors. And I hope we'll see you all back, I think, in November 1st. So the next Azra Payne APPD Hot Topic webcast will be on Tuesday, November 1st. And we will focus on opiates, an important tool for us pain physicians. And we will talk about the indication, getting on, staying on, and getting off if necessary. I hope I see you all back on November 1st when we talk about opiates. Thank you very much, and good night, everyone.
Good night. Thank you.